Hi, I'm Dr. Julie Harper, and I'm part of the Acne and Rosacea Symposium this year at the Innovation Academy meeting in New York City.
Hilary Baldwin, same.
And my part of the session today was to do an update on acne. Hilary was rosacea this year. We usually flip-flop a little bit on that. But some of my focuses for the update on acne were to really think about shifting our paradigm of how we go about treating moderate to severe acne. And what I mean by that is for so many years we would start with an oral antibiotic and then add combination topical therapies. And now I think really we can think about, at least in some people, reversing that, where we actually start with topical therapies and then at follow-up, if they're not enough better, then we can add those oral antibiotics. I do not want people to think I'm anti-antibiotic. I am not. But I do think if we can use them a little less in a chronic condition like acne, that's probably a good idea. I also did talk about some things that are on the horizon. We have a new FASN inhibitor that will be an oral medication available to men and women that can reduce sebum. We have some early data looking at that. And also briefly mentioned the therapeutic vaccine that is in development right now as well.
Vaccine's very interesting because it's not to try to prevent the development of acne to begin with, which is what I thought. It's to prevent moderate from going to severe, kind of?
I think the way I look at it is just to keep acne from being so inflammatory, because once it's inflammatory is when we then see, of course, acne, but also the sequelae of acne like scarring.
Gotcha. So I did rosacea. And there's not a whole lot new to talk about in rosacea. I had to dig pretty deep for this one. Talked about the newest of the medications, which is the low-dose extended-release minocycline. Very interestingly, in its phase 3 trial, not only did it go up against placebo, but it actually decided to take on doxycycline 40 milligrams modified release. I don't think I've ever seen that happen before in a phase 3 trial. But it paid off. Not only was it more effective, of course, than placebo, but also more effective than the modified release doxycycline in this study of 323 patients. Also, we're talking about oldies but goodies. We're talking about modified release doxycycline. We're talking about trying to be good stewards of antibiotics, especially in the treatment of rosacea, which is not an infectious condition. And we're using the tetracycline class of antibiotics because of their anti-inflammatory qualities, not because we're trying to kill some mythical organism. Now, if we had to use a full dose antibiotic, what would be your choice? If
I was going to use a full dose, it would be something narrow spectrum, like a sarecycline, for example. And I do think that's a reasonable alternative. It's been published as well for the treatment of rosacea.
They did a small pilot study, but it certainly makes sense in terms of being good stewards of antibiotics. Also talked about isotretinoin for rosacea, often forgotten. Very effective medication for all types of rosacea. And we have 2 new studies looking at very low dose, in fact, 20 milligrams a week. Not inferior to minocycline 100 milligrams every day. Of course, being effective as well as being, again, good stewards for antibiotics. Talked a little bit about neurogenic rosacea, normally your topic, but since this is my year for rosacea, what did you think about the idea of fecal microbiome transplant for neurogenic rosacea?
Well, I'm going to refer all of those patients to you, is what I think about that. But I think it talks about, the understanding of the pathogenesis of that very complex presentation of neurogenic rosacea. It may be even a little bit more than rosacea. I don't know, but those are challenging patients. They are in pain. And we are going to have to get out of our comfort zone. That's pretty far out of our comfort zone.
Very far.
But we're going to have to get out of our comfort zone to treat them effectively using things like neuroleptics, gabapentin, pain creams, things that we don't normally use for rosacea.
And gabapentin, very high doses.
High dose.
About 10 times higher than I normally use, which is perhaps why it hasn't worked for me in the past. But these patients are really suffering. And again, yes, outside the box is the way to go for them. And finally, a little bit about ocular rosacea, which we often don't talk about, just the mechanisms that we have. And we have 2 new drugs out for dry eye disease, which has not been studied specifically in rosacea, but certainly something that could be tried if ordinary drops don't seem to be doing the trick.